Good evening, everyone, and welcome to the EUROGEN webinar series. Just before we get started, I would like to take a couple of minutes to explain a little bit about what EUROGEN is and does. EUROGEN is one of 24 European reference networks created by the European Commission and since 2017. And they all deal with patients with rare and complex diseases. And we deal with rare urorectogenital diseases and complex conditions. So all conditions that need highly specialised surgery where the expertise is rare. And we're currently 56 healthcare providers across 20 member states. We aim to improve care for patients with rare diseases. And you may have noted some of our activities. Well, I hope you saw from the slides at the beginning, we can do cross-border virtual case consultations using a secure system provided by the European Commission called the Clinical Patient Management System. We would welcome any inquiries about tricky cases. We also work on clinical guidelines together and education and training activities. And we also have a EUROGEN registry, which we had a webinar on last night. So please have a look at that if you want to know more about how that works. So this evening's webinar, well, we're very excited to have three presenters with us here this evening as part of our colorectal series. And it's all about fluorescence in paediatric surgery this evening. The fluorescence imaging is a cutting-edge technique that has revolutionised surgical practices across multiple disciplines, including paediatric colorectal surgery. So our presenters are going to discuss the latest in this technique with us this evening. So tonight we have Dr. Carlos Giné, who is a paediatric surgeon at the Vall Barcelona Hospital in Spain. We also have Dr. Willemieke Tummers, who is a surgeon in training at the Princess Máxima Medical Center in Utrecht in the Netherlands. And then also Dr. Jetske Ruiterkamp, who is a pediatric surgeon at the Wilhelmina Children's Hospital Medical Center in Utrecht, again in the Netherlands. This webinar is eligible for EACME accreditation points for those of you who fill in the survey within 2 weeks' time. And it's also kindly supported by EUPSA and the Anorectal Malformations Network. So over to our presenters. Thank you so much for sharing your expertise with us this evening.
Thank you for the nice introduction. So the next 45 minutes, we will tell you all about fluorescence-guided surgery in pediatrics. We have divided this into three main topics, knowingly neonatal use, pediatric oncology, and colorectal surgery. And as already mentioned, questions and discussion can be done afterwards. So the image-guided surgery is nowadays widely used in a variety of surgical fields. Often fluorescence is used to visualize the specific details, for example, blood flow or lymphatic structures, or it's also used for tumor identification. And ICG is the substance mostly used to eliminate those structures, and it can be made visible with near-infrared light during surgery. So it's used real time, but you need a specific camera for it. And as I previously mentioned, we will discuss these three main subjects relevant for pediatric surgery, and we will start with neonatal use in a minute. I would first like to address this very helpful dosing and timing chart of the International Society of Fluorescence-Guided Surgery. And they have a specific chart for pediatric dosing. It's available on their website. And for instance, if you want to do bile duct identification, you use ICG intravenously. And if the patient is under 25 kilos, you use 0.1 milligram per kilogram of the ICG, and you administer it between 45 minutes and 2 hours prior to the surgery. I have no conflicts of interest to declare. And I will now start with the neonatal part of this presentation. I will discuss relevant up-to-date literature and safety of ICG in neonates, as well as one interesting case report and our own experience on fluorescence guided surgery. It's on esophageal atresia. We have also some information about a Dutch upcoming study in neonates to share. So first, if you search on PubMed regarding neonates receiving intraoperative fluorescence, it results in 13 articles. One is a review about safety. It's our own review, and I will tell something about that shortly. We also found 8 retrospective studies. They're all single institution studies, about 10 patients each. And it's, for example, on bowel perfusion. There are also quite some case reports on several subjects. I will discuss the safety, of course, and bowel perfusion. It's on patients previously diagnosed with NEC, so it's on strictures. There's an interesting retrospective study on neonatal cholestasis, and I will discuss one interesting case report. So first, to start with the safety of ICG, we published a review in 2022. It has 8 studies included, and all but one report on adverse events. 2 studies reported that there was temporary dye retention in the skin after subcutaneously used ICG, but that disappeared fully after 2 weeks. And no other adverse events were reported, especially no allergic reactions. And this is suggesting that the ICG is safely used in neonates, though the results are limited by patient numbers. Only 18 neonates could be included in this review. And just to mention, ICG is contraindicated in case of a known iodine allergy, hyperbilirubinemia, or thyroid disease. So the first retrospective study I would like to discuss is a study on bowel perfusion. It has included 13 patients, and it's published in 2023. It's on the laparoscopic surgery in case of a stricture after NEC, and the median age of those patients was 60 days. And the ICG was first administered to identify the stricture site, and the second time to analyze the anastomosis. So the stricture site was better recognizable with the ICG because it accumulated at the stricture site and also had a delayed fading. And further, in 1 out of 13 anastomosis, an extended resection has been performed based on the ICG findings. And in conclusion, ICG was feasible and safe for stricture identification, but also for anastomosis evaluation. In this second retrospective study, which is published in 2024, it's about diagnosing biliary atresia with ICG. 16 patients are included, and the ICG was administered 12 hours prior to surgery. And during this surgery, also the conventional cholangiography was conducted. And in 15 patients, biliary atresia was diagnosed, conventional, but with 100% confirmation of the ICG guided. And one of the limitations was that the liver uptake of ICG could interfere with the image of the gallbladder and the extrahepatic biliary tract. And it also seems to me that it was a highly selected group, or patient group, because all but one of the patients had indeed biliary atresia. These are the pictures from the article itself. So in figure 1, you see obviously the liver coloring very green, but also the gallbladder and the extrahepatic duct. And in figure 2, there is a biliary atresia. You see the liver, but you don't see the gallbladder and the bile ducts. So it seems to be very useful in diagnosing biliary atresia, but further research should be done. We cannot conclude too much on only this one retrospective study. And then this is the interesting case report I wanted to show you. It's on duodenal web identification by ICG. And the ICG therefore was administered through the nasogastric tube. It accumulated proximal to the web, and therefore the web was very easy to visualize. It's not really high-tech use of ICG, but it can be helpful in practice. And then to summarize the findings out of the literature, this is a review, and it's a very nice summary of all options of fluorescence-guided surgery in neonates. It's from Spain, and it describes the experience of the authors, as well as a complete overview of all available literature. It offers you more information than I am able to discuss during this presentation. And more importantly, they also conclude that ICG is a promising tool in neonates, which is safe and feasible, but also beneficial for neonates. It can be contributing to surgery, but especially in the complex procedures. In our own hospital, in the Wilhelmina Children's Hospital here in Utrecht, we performed about 20 procedures with ICG in patients with esophageal atresia, and we used the ICG for anastomosis evaluation. At the moment, the intensity is estimated by the surgeon, but we are also analyzing more objective methods like time to peak to predict anastomosis outcome. I can show you a video. So over here, you see the anastomosis of the esophageal atresia, and close to the instrument, which is there for some measurements. We are now adding some settings, and then I can go to like 50 seconds further. Injecting the ICG has already been done. And then you see the lungs coming up, and afterwards also very quick, the proximal esophagus. And then you see that in seconds later, also the distal esophagus is going to light up. But also interesting, this part of the anastomosis, which always stays a little bit more dark. And that part of the anastomosis, which is not very well perfused, the white thereof may also be an indicator of anastomosis outcome. So we're looking into that as well. And then last but not least, we are setting up as we speak a Dutch prospective study, and we cooperate with the University Hospital of Groningen. It's called Imagine, and we are evaluating the feasibility of ICG in infants with NEC, intestinal perforation, intestinal atresia, and malrotation. The primary goal is feasibility of the ICG and also image and interpretation. And we also want to see if the accuracy of ICG can be compared with a normal visual analysis, or if it will be better. And hopefully the paperwork will be soon completed, and then we can start inclusions this year. And now I want to give the word to Dr. Willemieke Tummers, who is going to tell us all about pediatric oncology.
Thank you so much. I will start sharing my screen in a second. There we go. Is it working? Yes.
Yeah, we can see it, yeah.
Okay, yes, perfect. So thanks. I will indeed talk about fluorescent guided surgery in pediatric oncology. As some of you probably know, is that in the Netherlands, all the cancer care for children is centralized in the Princess Máxima Center. So we have the advantage there that we can see quite some number of patients with oncologic disease, because what we all know is that solid tumors in children are rare and they often occur below the age of 10. And due to the smaller dimensions of these children, it's important to balance between an incomplete resection and removal of too much healthy tissue. And what is another challenge in these children is that almost all these patients receive neoadjuvant therapy, which makes it harder for the surgeon during surgery to distinguish between a vital tumor tissue and chemotherapy-induced necrosis and fibrosis. So we believe that modern imaging techniques are needed to make this surgery more accurate for these children. And we believe this can be done using fluorescent guided surgery. Because what we all want is we want to see that tumor cell within all the normal cells to make sure that we actually resect the proper thing. So what I'm going to talk about first is I'm going to first talk about the use of ICG in the pediatric oncology, and I will focus on lymph node imaging and tumor imaging. And in tumor imaging, we will talk about both the primary tumor and the metastases, and then I will make the transfer also to more tissue-specific imaging. So what we did in the Princess Máxima is we did a study where we wanted to image the sentinel lymph node, which is normally, of course, done with a blue dye in combination with preoperative technetium. And we wanted to see if we could change that blue dye to ICG, because, of course, we know that the blue dye changes the surgical field, which is for the surgeon is not what we really want to. So what we did for these patients is that we gave one single injection of ICG combined to technetium to visualize the sentinel lymph node. And what we saw that in 10 out of 15 patients, the sentinel lymph node was even visible through the skin. So it was easy to determine where to make the incision. And all of the intraoperatively detected sentinel lymph nodes, almost all of them were fluorescent, not all of them, 95%, and all were radioactive. What was an advantage is that more sentinel lymph nodes were found using this technique compared to the preoperative imaging, and we saw a really high TBR of 6.5 during the surgery, so they were really clearly visible. So we concluded in this study that ICG was of additional value to the radioactivity, but you can't, in these children, you can't use it alone because there were some nodes missed. What we then moved to was using ICG for primary tumor imaging. We did that in osteo and Ewing sarcoma, and the reason to do that is because a lot of these patients have irradical resections, which leads to increased risk of local recurrence and the need for high-dose radio and chemotherapy in the adjuvant setting. So what we did is we thought maybe ICG can help us to determine the resection margin. We gave these children 1 milligram per kilogram and infused it 24 hours. Here are some results. This is a patient with a Ewing sarcoma, and here you see an example of a patient with an osteosarcoma, where you really nicely see the delineation of the tumor using ICG. This, of course, looks nice, but what we see with the use of ICG is that there is some limitation of the penetration of fluorescence through the bone. But when you use it for the soft tissue, you can nicely see the you can nicely see the fluorescence. And here, of course, the bone is cut, so then you also see it really nicely. Some other indication is that we use it for the metastases. Those are also osteosarcoma patients, because a lot of them get pulmonary metastases at diagnosis, and a lot of the relapses occur in the lung. And for long-term survival, it is needed to perform a complete resection of the tumor and the metastases. So therefore, resection of those pulmonary metastases is standard practice. Normally, those were always localized by the radiologist using CT-guided localization, because it's quite difficult to detect the lesions during surgery, which were seen preoperatively, and especially when you're doing this surgery using thoracoscopy. So what we aim to do is to see if we could use ICG to visualize those metastases. Here, the ICG was also given 24 hours preoperatively with a dose of 0.5 milligrams per kilogram. And in what we saw during surgery is that in 5 out of 9 patients, the metastasis was fluorescent during surgery. But after surgery, when we did the imaging also ex vivo, we had 100% fluorescent lesions. So that also shows that it's quite difficult in a thoracic cavity to perform proper fluorescence imaging. So what we concluded in this study is that you could use it as an adjunct to other localization tools, but at this point, you can't use ICG alone. That's why we believe there is there's a place to not only use ICG, but also switch to tissue or tumor-specific imaging. Because here you maybe see an animal, but wouldn't it be perfect if it looks like this? So what we did is we aimed to develop a tissue-specific fluorescent agent for neuroblastomas. As most of you know, a neuroblastoma is the most common extracranial solid tumor in children. It grows along the sympathetic nervous system and mainly in the adrenal glands, and it has this growth pattern where it encases vessels. So it's often quite difficult to resect. And these patients always get preoperative chemotherapy and afterwards surgery. So a lot of the tumor already gets necrotic or fibrotic. And for the surgeon, it's really difficult during surgery to determine what is the vital tumor that definitely needs to be resected, or which is the tissue which I can leave behind because it's just too dangerous to resect it. So we wanted to make a tool to help the surgeon find the vital tumor cells. And what we know in this tumor is that it overexpresses GD2, and that this expression is retained after neoadjuvant therapy. So we developed a fluorescent agent, which is based on dinutuximab, which is used for the adjuvant immunotherapy in these children, and we conjugated that to the fluorescent dye iodide 800. We first, of course, did an extensive preclinical validation of this agent, and afterwards we determined the optimal dose and timing to translate it into humans. So we developed a first-in-human phase 1/2 study where we're going to investigate 3 different dose groups and inject this agent 4 days prior to surgery. As some of you might know, is that trying to perform a first-in-human study in children is really, really hard. So we're already quite long in the submission process of CITES, but we hope to include our first patient end of this year. And then hopefully we will be able to show some of the tumor targeting results in pediatrics. What are we going to plan to do in the future? So together with Birmingham, we're going to do the study to improve the lymph node detection for Wilms tumors using ICG. And another study, what we're going to do is visualize ureters using a ureter-specific imaging agent. This is an example of this agent in adults. And the last thing we want to do is not only perform the tumor-targeted study in neuroblastoma patients, but also in sarcoma patients, because as I showed you, ICG gives some nice results, but it's just not good enough. So what we did is we determined from some tissue which is coming from a patient which was neoadjuvant treated to see if there was still enough GD2 expression after neoadjuvant therapy. And we also saw that in these sarcoma patients, there still was GD2. So we hope we will be able to target that during surgery as well. It is, of course, important that we are able to visualize things using fluorescence. But which is maybe even more important is that we investigate what it actually is that we're seeing. So what we really believe in is that we need to make this post-operative evaluation of the combination of the preoperative scans, the intraoperative imaging results, so the intraoperative fluorescence, and the pathology. So what we did is we made this patient-specific cutting guides based on the scans preoperatively, and those are used by the pathologist to actually slice the tumor so that we can exactly correlate the imaging results of the preoperative scans and the fluorescence back to what the pathologist sees. So here is an example of that. So here you see those cutting guides, and there the pathologist knows exactly how thick to slice and where to slice, so that we can actually map all the pathology results back to the original scans and through the preoperative imaging. Because it's really nice, of course, that we can make things fluorescent, but we need to understand what it is that we're seeing when we're using fluorescence. So here you can also see this validation. What we use here, you can, for example, use a slide, take one of these slides of the pathologist and then correlate it exactly to the H&E stainings. So in conclusion, I believe that ICG is definitely useful for lymph node imaging. At this point, it probably never will be specific enough to guide an actual tumor resection. So tumor-targeted imaging is a promising next step. However, clinical translation is difficult. It is difficult in adults, but it's definitely difficult in pediatrics. And a correlation between the fluorescence and histopathology is really important to understand this technique and to actually show patient benefit. So I want to thank, of course, everyone from our research group who did all this hard work. And we will continue now with the talk of Carlos. So I will stop sharing my screen.
Hello, everybody. Thank you, Willemieke. That was impressive. Congratulations. And I have to say, I'm very happy to be here with you and grateful to be here with you this afternoon. Let me see if I can share my screen. I hope you can see them.
Yeah, that's perfect. Just want to put it into presentation mode.
Okay, so we put in presentation mode. Perfect. So I'm going to talk a little bit about the use of ICG in colorectal surgery. And as usual, like as many other things in surgery, we are always a little bit behind the adults, and we take profit of the experience of the adult surgery. And adults in colorectal surgery were doing that several years before us, and they have some very nice papers, a review and a randomized control trial that showed that the use of ICG changed the surgical plane in up to 20% of the patients, and the rates of leakage went down the half thanks to this technology. So what I'm talking about today, it's about the clinical burden and evidence-based indications in pediatric surgery. We will talk about some clinical cases, 2 words about pharmacology and safety because it's already been said, and some words in integration and innovation, and some key messages at the end. So when we talk about colorectal surgery in pediatrics, we have to face some technical challenges. We have to field interventions most of the time. The patients are very small. Normally, with histrons and anorectal malformations, we have patients with only several months of age. The dissection inside the pelvis is narrow and anterior and is difficult. Sometimes we have complex anatomy regarding the anorectal malformation, cloacal malformations, different kinds of malformations of the internal genitalia, etc. The dissection of the plane of the Swenson sometimes is difficult, and we need to evaluate the perfusion of the tissue to perform the anastomosis, to perform the mobilization of the bowel and the pull-through techniques. Fortunately, we have some technological advances that facilitates this dissection, many things, and the indocin in green is one of them that has a lot to do with the identification of complex anatomy and the evaluation of the tissue perfusion. So which are the objectives of the ICG? First, to provide an objective real-time visualization of the vascular architecture, and to enable precise selection of what to resect and where to put our anastomosis. It alters the intraoperative strategy in some reports up to 62% of the cases to the place where the perfusion is more adequate to do the anastomosis. And of course, that decreases the postoperative complications in terms of leakage strictures and necrosis because of ischemia. And it allows a better identification of anatomical structures. And this is not what I say, it's what the literature says. I have this beautiful review from the group of Rebecca Rentea. It's very recent, it's from last year, specifically in colorectal pediatric surgery. And you can see here that for Hirschsprung disease, many techniques have been benefit from this technology, Suave, Swenson, total colonic Hirschsprung disease with G pouches, etc. And mainly the use was to assess the perfusion, the vascular perfusion. Regarding the anorectal malformations, we have an open surgery as well, some cases. And what is very interesting, we have a retrospective single institution study from Lee et al. With 4 patients that use the ICG. The route was enteral through the distal colostomy to the rectum to assess the anatomy of the fistula before its ligation. This is very interesting, and it's what I'm going to show you more because we are very happy with this technique. And then for the colostomy closure, it's been used as well to see that the anastomosis is very well perfused. We have some reports from Rebecca as well regarding the open surgery of cloacas and some surgery over the vagina in some cases of Mayor Rokitansky. And they use, this is very interesting because they use this ICG intraureteral to visualize the urinary system to prevent the injury during the surgery. Of course, we have one case report about a rectal prolapse with a resection of a rectosigmoid, and some insights into the surgery for the fecal incontinence, Malone and Malone, for the urinary incontinence, for continence channel creation and bladder augmentation. And we have a very recent review from the group of Mario Lima and Tommaso Gargano. It's several months ago, and it's a resume of all the literature available in pediatric surgery with the use of ICG, and for the gastrointestinal surgery, you see that normally the use is to evaluate the perfusion. When he talks about the study of Lee et al. For the enteral administration of ICG to localize the rectoureteral fistula, and all the other things, as you see here, is evaluation of perfusion. So, published results by pathology, we have anorectal malformation, some retrospective series, a small number of patients, but it changed the surgical plan up to 31%, up to 3 patients. Where the plan was changed a little bit during the surgery because of the use of this technology. Hirschsprung happens the same, up to 62% of changing the strategy during the surgery. We have some neck-related colorectal stricture that's it's some before it was already said. And for the stomach closures, we have cases report, and with cloaca and Mayer-Rokitansky reconstructions as well, cases report, to enhance the identification of vascular pedicles mainly. Okay, so the indications are clear to assess the anastomotic perfusion, for instance, in the pull-through for Hirschsprung's disease and anorectal malformation, to identify the ischemic segments after necrotizing enterocolitis, to evaluate the complex pelvic reconstructions, including cloacal repairs and continent channels, to confirm that the stoma is closed in a very good perfusion situation. So these are some cases. This is a Hirschsprung's disease. It's a rectosigmoid Hirschsprung. We use in our institution the Swenson's procedure. And we use the device of Stryker, it's the 1688, that allows some different modes of visualization of the ICG. And I will show you in a minute. And you will see that with dissection, this is a posterior aspect of the rectum, that we reach the pelvic floor very, very low. And now it's the time to assess if what we are going to pull through is well vascularized or not. You see here the biopsy. And I want to stop in here this. You see here the biopsy, and you can see perfectly well the difference between the perfusion proximal and distal to the resection, to the dissection. So from the perineum, we get very low from inside, so we only need to dissect 1.5 centimeters. And then we take it out, we see the biopsy site, and we can perform our anastomosis. And we can use the same scope to assess the perfusion of the descended bowel, as you can see here. This is another similar case, a rectosigmoid, but I wanted to emphasize that it was another technology, and we have several modes of visualization. In this time, we have a segmental color visualization that you will see in a minute, that not only gives information about if it's vascularized or not, it gives information about the degree of perfusion, which may be very interesting in different cases. We reach the pelvic floor again, and now we are going to combine 3 modes of visualization of ICG to see how is it going to be our pull-through. When we inject the ICG, the first seconds, the first that you see is the blood supply in the vessels, and then in the tissue. And it's very nice because you can identify in the colon the vascular pedicles, if you have the marginal branch, or if you have the Riolano arc, and you can decide if you can sacrifice this or not. And now this is a segmental color visualization. You can see from hot to cold the difference of the perfusion, and you can see that the distal is absolutely necrotic or not perfused, and you will have the SPY visualization mode as well, that gives you an idea of the vascular supply. So it's very interesting at the end to confirm that the pull-through that you've done is well vascularized and well perfused, and we can do that with this technique. This device is a 1788, is the last tower of Stryker, and combines these different ways of visualization. Is not available everywhere, but it's a very nice device. So for the anorectal malformations, we use it mainly for the identification of the fistula. So the route that we use is the enteral by the distal colon by the mucous fistula. But the fistulas are different. There are some very tiny fistulas like this one, so the visualization is very, very nice. You can see exactly where the fistula ends and contacts the urinary tract, which is very good. But it's not always like that. Sometimes the fistula is not well visualized. This is one case that I was not very happy because we could not see that well where was the passage, the end of the fistula. You can see the dissection was nice, but we didn't see perfectly well where the fistula ended. You can see here the prostate, so it should be like that, but we didn't see it well. And in other cases, like this one, the fistula was very wide, so we had an immediate passage of the ICG to the bladder. So how can we improve this? We have a new technology as well, it's an infrared catheter that we can use through the urethra to visualize the urethra and the prostate, and we combine it with conditioning green. I'm very sorry to hear that this is not longer produced in Europe, and it's gonna finish in the near future. I don't know why, maybe because I was the only one using that. But for me, it's a very useful technology combined with ICG. You can see, you can put it through a Foley catheter from 8 or 10 French, which is as appropriate for these patients. And you can see that combine it with the ICG, you have a very nice view of where the fistula ends, to avoid the complication of leaving some fistula behind and the roof. And I have to say it's very fun in the surgeries, like you are in a discotheque. So you know exactly where to put your stitch, where to put your ligature, and how to proceed with your dissection. Obviously, there are cases that it's wonderful, and there are other cases that it's not that wonderful, but it's very, very helpful. This is a very difficult case, and it was a bulbar fistula, and the dissection was very long, because we like to go very, very little by little, and very close to this is the posterior aspect of the rectum. We have to dissect all the posterior aspect of the rectum to leave only the fistula behind. And you can see here the urethra and the prostate, so we can pursue with the dissection of the rectum a little bit farther, and we combine it with the ICG. This is the case that the ICG passed immediately to the bladder. That's it. So I can advance it a little bit. So you have here the prostate and the urethra, and then we used at that moment a 5 millimeter stapler. I think it's controversial. I know it's controversial, but we are very happy with this device. And we can see afterwards perfectly well how the fistula is ligated. So another useful trick is putting the ICG directly into the hydrocolpus. This is a hydrocolpus and a cloaca, one hydrocolpus, two hydrocolpus, the bladder in here. So you can see that it facilitates the dissection. This is the uterus, the ovarian, and the hydrocolpus. This is a very complicated case, but it's useful to identify the limits of the hydrocolpus. And this is a very particular case. It's a recent case from this year. And it was a baby girl with an anorectal malformation. She had a normal urethra, normal vagina, and no evidence of fistula, nor vestibular, not perineal fistula, not vaginal fistula. But she had as well colic atresia. So the distal colon was very, very tiny, very hypoplastic. So we put the colostomy in here, we put the mucous fistula in here, and we did the distal colostogram. We couldn't do the high pressure colostogram because we were afraid of harming the hypoplastic colon. It was not satisfactory. We repeated several weeks afterwards, and it seemed that there was no fistula there, and it was quite high. It was 2 centimeters from the skin. So we used this technology, the SPY-5 of Stryker, to see in open surgery if we had indocyanine green in the screen. So we put the indocyanine green by the distal pouch and open a little bit the P-SARP, and we saw nothing. So we go a little bit farther and we see something in there. We use the ICG and we see nothing again. So I was a little bit worried. We get a little bit deeper with the dissection, and now we can start to see the ICG. So we are very happy that this is the rectum, and we can continue with our dissection. And now that's very easy and fun. And here you are. All right, so regarding the pharmacology, I won't say too much because Jetske talk about that. Normally, when it's intravenously, I use 0.15 milligrams per kilo. And when it's for the gallbladder or for the liver, I use 0.25 milligrams per kilo. You can repeat every 15-20 minutes as needed, normally 5 or 6 doses, less than 2 milligrams in total if it's possible. When it's neonates, a little bit lower, and we have the onset of the fluorescence in half a minute, 1 minute. For the enteral route, there's nothing described. Lee et al. Describe an enteral dose of 1.25 milligrams. It is very, very, very little to me. I use 25 milligrams, and I mix it with 50 or 60 saline and introduce little by little in the distal fistula until I get some response. But we have very limited experience, and it's not standardized. Regarding the safety, as you know, the ICG is cleared hepatically. It has a half time in plasma less than 5 minutes, which is wonderful. And we have across 600 pediatric colorectal cases with no adverse events related to ICG in administration. We have minor events, self-limited minor events, the green discoloration of the unit, and the rate subcutaneous dye retention that normally in 1 or 2 weeks are gone. And contraindications, as Jetske said, the allergy to iodinated contrast and severe liver dysfunction, of course. So future perspectives. So the standardization, we need to get an international consensus regarding the dose, the time, and the interpretation criteria. We need some quantitative perfusion metrics. And this is not future, but the robotic and augmented reality integration, as this is a reality. We are using that already with the robot, but in bigger patients in our hands. And then we need more multicenter randomized trial to confirm reduction leak rates, operative times, and cost effectiveness scenarios. So key messages: the indocyanine green is a reliable real-time tool to evaluate the bowel perfusion and to help to identify complex anatomy in pediatric colorectal procedures. Optimize the resection margins and improves the quality of the anastomosis, reducing the ischemic complications. So we should be able to standardize the ICG in our daily activity, because it's quite easy to introduce if you have the device. And you have to remember the weight-based dosing, and to use checkpoints before the anastomosis, checkpoints of ICG, and to record and audit all your surgeries for continuous quality assessment. So I leave you some seconds to if you want to do a screenshot of the literature I use for this presentation, which is very interesting. And thank you very much for your attention, and I'll be happy to take any questions with my colleagues.
Questions from Dr. George Oliveros. He's from Ecuador, and he asked, do you think that ICG imaging could be useful in hypospadias repair, particularly for assessing vascularity during surgery? Carlos, have you ever used it?
I'm not doing urology, but the SPI-FI technology, the ICG for open surgery, it's used by the urologists and by the plastic surgeons for the grafts, to see the perfusion of the grafts. So I think that, of course, it's a good indication, very proximal hypospadias, if you want to know if the graft you are putting on it, it's perfused or not. But I don't have experience myself on this area.
No, but I believe they are doing it. I don't have it myself as well. But in Switzerland, there is also a urologist doing a lot of fluorescence with ICG, and I believe he does it.
Okay. And second, what would be our recommendations to give to surgeons who are just beginning to use the ICG the first time in their clinical practice? Where to start is the question. Thank you, George, for your questions. Very nice. I think it's best to start with a procedure you already know and you don't really think you definitely need to use it. The first time I tried it was in a slightly older patient with a stoma repair surgery, and it was immediately very helpful, but it was some difficult with the technique and a camera and just trying to see what works and how it works. So for that instance, a neonatal case, I wouldn't start with that right away, because also there you have more time pressure, but it is all quite easy to do. So there are no really limitations, but I think a surgical procedure where you're familiar with, I would start with that.
And I would also say you need to just do it, and you need to do it over and over again, because you need to understand what is the green you're seeing, because it's not just green yes or no. It's like it is a spectrum of green. So you need to understand what you're looking at, and you only get that understanding if you just use it a lot. And I think also having a team which is used to look at those images is really important to be able to actually use the technique for improving your clinical practice.
I agree completely. I mean, if you have the technology, it's a very safe technology to use. And I just started to do to check everything. I did even the pectus surgery, the thoracic surgery, everything. You just use it and you play with the gain and you try to understand what you are seeing, how can you see it better, and you will be surprised at what you are finding. And it's a way. And then when you are doing some resections, you will see it, that it's very useful for you. But do it if you have the possibility. I will suggest you to use it then in the maximum cases you can.
Okay, thank you. Just quickly give one more minute, just if anybody has any other questions they want to ask now. So we're actually already on 7 o'clock. So we've already reached that time. But just while we just wait if anybody else wants to ask anything, just please fill in the survey, everybody. So check our website. If you have any questions or anything you want to, then just you can email me afterwards, as I say. So there's Jorge there saying thank you for the answers. Oh, okay, a question from Nabila. And another one from Roni now. So typical. So hope you can see those. So we'll take the one from the biller first, I think.
So there's a question about the costs of the ICG, and I think especially the camera in the resource constrained countries. I don't know if we have the answer for that.
I don't have the answer for that.
Because
No.
the ICG won't be the problem, I guess. It's
no,
not
the
that
ICG
expensive.
is not that expensive, but the camera, of course, is really expensive.
That's
So
right.
that is a problem. So you need, as a hospital, you need to use it often enough to make a business case to be able to buy a camera, or because the camera is, of course, expensive.